Perfect. Okay, so good afternoon, everyone. I'm Jessica Lim. Thank you, Beth, Heidi, and Tina for inviting me to speak, and thank you guys for coming. We work really hard here every day, but this is the 1 week that we go crazy, so I appreciate all you guys coming. So I know I have the talk right before lunch, so don't worry, I know we're all hungry, so I'll keep it short and concise, and unfortunately I have no disclosures. I support myself financially. So first off, we'll start off with a quick review of diabetes. So generally there are 3 types. Type 1 is when your pancreas is unable to produce insulin in response to glucose levels. So this results in daily injections, and this is previously known as juvenile diabetes because it was often seen in the younger children, but now we know it's not true anymore. Gestational diabetes is in patients that are pregnant and unable to secrete enough insulin that's needed during pregnancy. And then there's the type 2 diabetes that's most widely known in our field. The body causes blood sugars to rise higher than normal, and the pancreas secretes insulin, but the cells don't respond properly. So this is also known as insulin resistance. So I'll be focusing on type 2 diabetes. So some risk factors for type 2 diabetes, we have overweight, obesity, physical inactivity, race and ethnicity, age, hypertension, and hyperlipidemia. And there's also what we know as prediabetes. So prediabetes occurs when blood glucose levels are higher than normal, but not yet high enough to be diagnosed with diabetes. There's an increased risk of developing type 2 diabetes, heart disease, and stroke, but it's good to know that everyone with prediabetes will not progress to diabetes. So this occurs in approximately 84 million adults. 1 in 3 have prediabetes. And out of the 84 million, 90% do not know that they have it. So I put here, there's 3 ways to diagnose diabetes: the hemoglobin A1C, fasting plasma glucose, and the oral glucose tolerance test. So you could see here the hemoglobin A1C less than 5.7 is normal, 5.7 to 6.5 is pre, and 6.5 and greater is diabetes. So I also included the hemoglobin A1C because that's the average blood glucose over a 2 to 3 month period. The good part is you don't need to be fasting. And I put the correlating blood sugars here because I feel that our patients don't really know how much their hemoglobin A1C is when they hear about it to the actual blood sugar. So we see here 5% is 97, 9% 212, and 13% is 326. And also, I just wanted to discuss some staggering facts about diabetes in the United States. More than 30 million Americans have diabetes. 1.5 million cases are diagnosed each year. Today alone, 4,110 Americans will be diagnosed with diabetes. And diagnosed diabetes costs America $327 billion per year. And it remains as the 7th leading cause of death. And I found a map from 1994 from the CDC showing the prevalence of diagnosed diabetes among US adults. So as you can see, it generally has a pale yellow, light orange color, and according to that grid, that would say less than 4.5% to 4.5 to 5.9%. So we'll fast forward 10 years to 2004, and you definitely see some more darker oranges and reds. And the latest one that I found is in 2015. So you could definitely see the darker red accounting for greater than 9%. And I would definitely say we have no more of this yellow, even light orange. And I could bet you in a few years, probably even now, that this is all red. So here's some diabetes by race and ethnicity. First place, you could say, is 15.1%, the American Indians and Alaskan Natives. So how are diabetes and cardiovascular disease related? So heart disease is the #1 cause of death in the United States, and heart disease is a major cause of morbidity and mortality among those with diabetes. Those with diabetes have a higher prevalence of heart disease, a greater extent of coronary ischemia, and more likely to have an MI or a silent MI. So type 2 diabetes is known to be a CHD equivalent. And what that means is patients with type 2 diabetes without a prior MI were at the same risk for an MI and coronary mortality as patients without diabetes who have had a prior MI. And I came across some 3 interesting studies. First is the Framingham Heart Study. And in the Framingham Heart Study, the presence of diabetes doubled the age-adjusted risk of cardiovascular disease in men and tripled in women. And the second is the Mr. Fit trial, which stands for Multiple Risk Factor Interventional Trial. And in this trial, there were 5,163 men who reported taking diabetes medication. And of those, 9.7% died from cardiovascular disease over a 12-year period. In contrast, this is to 2.6 cardiovascular death rate for those who do not take diabetic medication. And lastly is the Emerging Risk Factor Collaboration Group, which included 530,000 patients with no history of MI, angina, or stroke at the initial visit, but patients with diabetes had an overall risk of CHD twice that of patients without diabetes, with similar risk of cardiac death and non-fatal MI. So as clinicians, let's discuss some ways that we can improve diabetes and cardiac outcomes. Of course, well, first and foremost, diet and exercise. We have the Mediterranean diet, which focuses on eating plant-based foods, fruits and vegetables, whole grains, nuts, limiting red meat. There's also the DASH diet, similarly, vegetables, fruit, low-fat dairy, moderate amount of grains, fish, poultry, and nuts. And in terms of exercise, the American Heart Association recommends at least 150 minutes per week of moderate intensity aerobic activity or 75 minutes per week of vigorous aerobic activity or a combination of both, preferably spread out throughout the week. So statin therapy should be added to patients regardless of lipid levels for diabetic agents with overt CVD or without CVD, but over the age of 40 with multiple risk factors. So that includes family history, hypertension, smoking, hyperlipidemia, or a 10-year ASCVD percentage of greater than 20%. So the ASCVD, it's an atherosclerotic cardiovascular risk calculator, which allows healthcare providers to estimate, and even patients to estimate 10-year and lifetime risk for atherosclerotic cardiovascular disease, which is defined as either coronary death, non-fatal myocardial infarction, or fatal or non-fatal stroke. So it's similar to like, you can look it online and input your age, systolic blood pressure, total cholesterol, HDL, if you're taking any hypertensive medications, cigarette smoking, and if you have diabetes. So here are 2 studies showing the benefits of statins in diabetic patients. There was the 4S study showing that simvastatin versus placebo. Simvastatin decreased major CHD events, so that was 22.9% versus the placebo, 45.4%. And there was the CARDS primary prevention study, where it shows that the use of atorvastatin decreased acute CHD events with 5.8% occurrences versus the 9% with the placebo. And the 2018 ACC-AHA guidelines gives a class 1 recommendation for moderate intensity statin therapy in patients 40 to 75 with diabetes for primary prevention. And if possible, we would like to decrease the LDL goal by 70 or lowering it by 50 to 60%. Typically, we'll start off with atorvastatin. Rosuvastatin is used for those that experience the muscle aches. We have Zetia, which can be used if patients that cannot tolerate a statin or in conjunction with a statin. And last but not least, I think of this as the miracle drug, the PCSK9 inhibitors, also known as Repatha or Praluent. And that's an injectable drug that's injected either monthly or biweekly. And when used in conjunction with a statin, it can reduce LDL by 60%. Hypertension affects approximately 80% of patients with diabetes and for every 10 millimeter reduction in the systolic blood pressure, that leads to a 12% decrease in fatal and non-fatal MIs. The goal you could see is 130, less than 130 over 80, and we also see the use of the ACE or an ARB since it has shown to have the cardiorenal benefits. In terms of aspirin, we used to say to give aspirin to everyone, and it's true that aspirin is effective in reducing cardiovascular events in diabetic patients with established CVD, but it still plays a controversial role in patients without previous CVD events. And then glycemic control. So that's important in our diabetic patients. Generally, we aim for a hemoglobin A1C of less than 7, but there could be more stringent goals, less than 6% for individual patients, or less stringent, less than 8%, could also be appropriate for the elderly patients, patients with severe hypoglycemia, limited life expectancies, and individuals with comorbid conditions. And here we have the ACCORD trial, which was a trial which decided if intensive glycemic control with a hemoglobin A1C of less than 6% can reduce cardiovascular disease in patients with usual care. So that's usually a hemoglobin A1C of 7 to 8. And actually the trial was stopped. It was supposed to last for 5 years, but they stopped it after 3.5 years due to a high number of total cardiovascular deaths in the subjects assigned to that intensive less than 6% therapy. And then interestingly enough, there are some diabetic medications that have been shown to be beneficial in cardiovascular disease. One are the glucagon-like peptide 1 receptor agonists, and also the sodium glucose cotransport 2 inhibitors. And 2 recent groundbreaking studies, one was being the LEADER trial, and also the EMPA-REG trial. So the LEADER trial randomized 9,340 patients with diabetes and CVD to liraglutide, which is Victoza, and found that it reduced cardiovascular death, MI, and stroke by 13%. And also the EMPA-REG trial. That's the empagliflozin, which is Jardiance, cardiovascular outcomes and mortality. So there was a 14% risk of stroke with 14% reduction in primary outcomes of CV and death, but no significant difference in MI or stroke. So generally a broad topic, but I hope I gave you guys a crash course on diabetes and cardiovascular disease. And things to remember is that diabetes is definitely on the rise and a CHD equivalent. And a multi-specialty collaboration must be used for the diabetic management of the patient with diabetes and cardiovascular disease to decrease cardiovascular risks, hyperglycemia, and ultimately to improve outcomes. Thank you.